Okay, today is Monday, April 2nd, 2018. This is Hannah Crawford for the Global Polio Eradication History Project with Dr. Rebecca Martin in the Broadcast Department of the United States Centers for Disease Control and Prevention in Atlanta, Georgia. We've had one pre-interview session in preparation for today. Todd Jordan is our videographer. As requested by the project, I'll provide a little contextual information. Dr. Martin has over 20 years of experience working in international health with expertise in immunization, HIV, and health system strengthening. Prior to her current position as director of the Center for Global Health, she served as the director of the Global Immunization Division from 2012 to 2016. The Global Immunization Division leads polio eradication at CDC. Today's oral history will focus on intersections between Dr. Martin's work and polio eradication. Thanks for being here.
Thank you.
First off, do we have your permission to conduct and record this interview?
Yes, you do.
Great, thank you. And we'll follow with a release form at the end. So to begin, we always start at the beginning in oral history. So if you would state your name, say where and when you were born, and share a bit about your early life. That'd be great.
Sure. My name is Rebecca Martin. I was born in April of 1965, and I was actually born in Bangkok, Thailand. My parents were living in Cambodia at the time, but there was no place, hospital that I could be born at, so my mother flew to Bangkok to have me. So I was born there. Early years, my father was with the U.S. State Department, so I grew up overseas. And in the early years, actually from 1969 to 1973, we were in Kabul, Afghanistan. And from there, we moved back to the United States. And then later in my life, I did my high school years in Kenya. So we moved around quite a bit, and I went back to the United States to go to university. I think just looking back on that, having been in countries of low income settings and having seen people on the street, kids on the street, begging for food, begging for money and for food, but really seeing many diseases that you don't see in the United States. People with paralyzed legs, for example. I think that's where I know I saw my first polio case in Kabul, Afghanistan in the early 70s. And seeing children just sitting there not being able to move really struck me and stuck with me in my career and in my later life in determining what I was going to do as I grew up.
Did anybody explain what you were seeing when you were a child?
Both of my parents did, and they were very clear to make sure that we understood what we were, that we were fortunate to have what we had, and that we were able to be in these countries and to see and to learn about different cultures. For my parents, it was very important that we appreciated, understood different cultures, that there was value and significance in things and things we could learn. And I remember one Saturday morning in Kabul, we'd always go to the big bazaar and do the vegetable and the fruit shopping. And there were there was a family sitting on a blanket on the side of the street. And this is where I saw this one child with paralyzed leg. I've seen cases of leprosy on the sides of the road too. But really being able to understand that people didn't have access to services, access to health care, didn't have homes to go to, and were just surviving minute by minute on the street. It's something that stuck with me quite a bit and over the years. It's funny because my father also, when he was young, he grew up on a farm in North Dakota, and he had lost his right hand in a farming accident. And so he was also a bit of people wanted to come and stare at him because here was a man with a hook. So it was interesting to see the give and take on the street between us trying to understand and see what we were seeing, and then also my father being very, very familiar and friendly with people to explain about his hand.
So you grew up with both. Did you intend to go into medicine?
You know, it's funny. I always liked the health component of it, the science. Since I think 8th grade, when I was in grammar school, I wanted to do something in the science field. I started my PhD in microbiology and was very excited until it was, I think, 3 a.m. one morning, and I was busy feeding my cells. We were looking for the human receptor on this virus, and I was like, I really want to see the end of my results to see what I'm doing. And that's when I discovered public health and I moved over into School of Public Health and started infectious disease epidemiology to be able to take that science and bring it into practice to change people's lives.
And that was at Bloomberg at Johns Hopkins?
Yes, I was at Johns Hopkins School of Public Health, yes.
Okay, got it. Could you talk a bit about your time there and your interests? How that evolved?
Yes. So always having been interested in the sciences, I think vaccines were something that always interested me and just amazed me that you could give somebody a vaccine and prevent a disease. And why weren't we giving those vaccines to people where I had grown up and I had seen people on the streets as well? And how do we make sure that everybody had access to life-saving vaccines? I think this is something that always amazed me, is both the science, how the immune system could respond, and how we can have so much memory of something that when we're exposed to it, our body can respond and protect us. So I think that was something that always interested me. As I learned more and more about how we could apply vaccines and how we could get vaccines to different communities, this was what excited me, and I said I wanted to be involved in this work. I did my doctoral dissertation in Haiti on high-titer measles vaccine. And there it was an idea that with measles vaccine, let's give more a higher titer of the virus so that we'll really prevent measles. And we can give it at younger ages before the normal 9 months or 12 months of age. What we found, though, was that by giving such a large dose of the virus, of the inactivated virus, that we actually suppressed the kids' immune system. And with that, then they were exposed to other respiratory and diarrheal diseases in their communities. And they were dying, had higher mortality due to that because their immune systems were suppressed. So we did the follow-up studies in Haiti because it had been one of the trial sites for the high-titer measles vaccine. And it was really important to be involved in that work, and I felt very privileged and honored to be able to do that and to look at the nutritional and the immune status of the kids. We looked 24 months after vaccination, and by that time the mortality factor had evened out such that both boys and girls were able to thrive and survive after that. The vaccine, of course, was pulled quickly and stopped, and luckily, having able to follow those cohorts of kids, we were able to get those data to make sure that happened.
So from your dissertation, I know that eventually you went into the National Immunization Program? Baltimore?
Correct. Yeah, so while I was finishing up my dissertation, I was working at the Maryland Department of Hygiene and Mental Health at the same time. And I started in foodborne outbreak, but found my way over to the immunization program. And we were working domestically in the counties, making sure, kids got vaccinated, adults got vaccinated, travelers got vaccinated. And it was always that Friday afternoon call of like, we have an outbreak of, hepatitis or measles in a prison or in a school. Or my favorite was when a class had gone to a pet store and they'd all played with these puppies, and then the puppies had been positive for rabies. And the puppy had licked all the kids, so it's like, now what do we do? So, of course, having to deal with those kinds of issues gave me a lot of experience in understanding how we apply vaccines and how we make sure that we can respond in a timely manner. After working at the Maryland Department of Health, I came here to Atlanta, and I've been here since 1997, first with the National Immunization Program, working on pertussis, Hib, and rubella. There again, it was interesting because we were seeing that more and more outbreaks of pertussis in adolescent. And it was the kids were getting vaccinated, but there was waning immunity over time with the vaccines, kids who had not been exposed to pertussis, so that they were getting getting pertussis into their adolescent ages, as well as infants who were too young to be vaccinated. And so you saw this mix of young mothers whose babies hadn't been vaccinated, who got pertussis and gave it to their infants. So there's been a lot of work to describe how we make sure we protect adolescents. There was at that time then another booster dose of pertussis vaccine, the acellular pertussis vaccine that was added to the schedule. So that was great to be part of that, investigating outbreaks of rubella up in New York. And there it was, again, it had been mainly people from Guatemala, Honduras, who had moved to the United States to work and who had not been vaccinated as children. So we saw a large outbreak of rubella in adults. And it was a population that did not want to be investigated by the government or have contact by the government. So it was very hard to find them. And we had to go into bakeries, we had to go in different places to offer vaccine and to trace down and track people who were infected to make sure their contacts got vaccinated before they had symptoms.
So was that the beginning of your surveillance experience?
I would say the surveillance began at Maryland Department of Health because we did a lot, foodborne outbreaks required a lot of surveillance as well as the immunization program, where we really reported diseases weekly to the CDC at the time. So to understand how that whole cycle works from a county to a state to a national level to make sure that we can monitor and track diseases, yeah.
So you've mentioned measles, pertussis, you have experience with rubella. I remember you saying over the phone that you were never formally assigned to polio, which I think is really interesting, actually. So I wonder about your perspective on polio, having this background in other vaccine-preventable diseases.
It's interesting because I don't think anybody can ever get away from polio, and I think it's always the importance. When I first came to CDC, I had been planning to work on polio, but then they had created the international unit and moved polio with it. So it was watching it from afar to begin with, but when I went overseas with the Global Immunization Division at the time in 2002 to Kenya, I was assigned to work on strengthening the immunization programs, do elimination for measles, rubella, but polio, of course, comes right into your work. And it was my first time to really sink my teeth into understanding the vast amount of work that is being done by polio around the world at that time and had been done since the early 90s, late 80s of moving forward to vaccinate these large national immunization days that were held. And not only that, but cross-country. I was in Kenya, and we would do campaigns with South Sudan, Somalia at the time, or with Ethiopia, across borders. And these were huge campaigns and trying to reach all the kids under 5 years of age. So I'm really involved in making sure that we could do those campaigns. The other piece is the Stop Transmission of Polio teams. And they would come out. At that time, more of them were coming from the U.S. Later years, we saw more of them come actually from other countries to participate and stop. But at that time, it was mainly EIS officers or people at CDC who had very strong interest in going out for 3 months to be part of the polio. And they would come all new, ready to go. And we had 8 countries that we covered in Kenya as the inter-country program. And we would do a training for them. And then when they'd go to their country, we would follow up. So I would go to Tanzania and check in on them and see how they're doing and make sure that the surveillance people were out in the field, the data people actually had access to data, and then we'd follow up at the briefing with the Ministry of Health at the end to see how the program went and to review recommendations. But that was my real foray. It was 2002 into polio.
Later on, you went from the African region to the European region. Did you go directly?
I did. I spent 2 years in HIV between the two. I was based in Tanzania, but I'll tell you, I kept my eye on polio still, because once you get it in your blood, you really want to be part of that eradication. Really, you see that it can be done, and how can we make it happen? So in 2008, I moved to Copenhagen, which was the headquarters for the WHO European Regional Office, and we covered 53 countries in the region, going from the UK all the way over to the Central Asian republics. And so it was quite a huge piece of work. But then you really figured out, like, the Western Europe really wanted more of the technical, just the guidance. And they weren't so much interested in, the assistance or implementation. We've got it covered. But when you went over to the Central Asian republics or into the Caucasus, really there was a need still for helping to do technical assistance. So helping them with their surveillance, making sure that it was of quality standards, conducting training for surveillance officers, making sure that when they conducted campaigns that vaccines were getting to the kids, and really doing all of that building of a whole surveillance system and the immunization program to make sure that vaccines were reaching children.
What were some of the challenges working in former Soviet countries?
I went in pretty pretty wide-eyed, but I didn't really understand when I first went in what I was really addressing. You read about things, but being in that environment is very different, and it is different to understand all the political complexities and the cultural issues that you had all these countries, but none of them were the same, and how you had to tailor your work with each one of them and the personalities and understanding the political situation. They very much said and did what you wanted them to do in terms of it was very much like with the Soviet Union, the system that had been left in place was like every kid gets put in a book and there were 8 registries, so a child could be in 8 registries for different things. But at the same time, you weren't really sure what the quality was. For example, we found things where they would say kids were vaccinated on Sundays when we knew clinics were closed. Or we'd find out that vaccine wasn't there, but then they reported 100% coverage. And it's not everywhere, but you had to find those pockets. And you had to do it in a way because many governments were not able to talk about their diseases, in such that you couldn't say you had an outbreak of measles or an outbreak of cholera. So if a health officer can't report it, you had to be very careful. They wanted to work with you to stop it, but they couldn't talk about it publicly or with the Minister of Health. So you had to know how to navigate this. And I'll give you one really strong example is in 2010. It was January. I'll never forget it. We had a report of an acute flaccid paralysis case in Tajikistan, in Dushanbe, the capital. And we're just like, oh, it's just going to be another AFP case. The region had been certified polio-free in 2002. So we had just been going through every year, making sure everything was fine. Well, in fact, it was a positive. It was a wild polio virus type 1. And we all froze. How did this happen? And we start to do more investigating. In the end, there were over 430 cases of polio that happened in Tajikistan. Well, in the interim as well, people moved. It was the time for the season for people to migrate. And people had gone, there were over 7 cases that were reported in the Russian Federation. There were cases reported in Turkmenistan.
To be explicit, why? Why would they not want to report it?
It was part of the system in terms of understanding how things are controlled. And if there were not going to be reporting any bad news or things that were happening. So you couldn't report an outbreak of polio because it showed flaws in the system. It showed that people were getting disease in a country where they wanted to show that everything was fine and there were no problems. So it was very much the control of the whole situation. Yeah.
Mm-hmm. Do you remember your response to that? Do you remember what you thought?
I remember. I clearly remember. I'm like, why wouldn't you want to report this? There's a lot of help that could come because they needed access to vaccines. They couldn't afford it with their budgets. We thought how important we can stop this to make sure that it doesn't spread. But the thing I would mention is that all the countries did all the measures to stop it. If they reported or not, they really took all the actions and they really made sure that they were doing surveillance and vaccinating. But this was all foreign to me. I didn't understand why a disease was considered to be something of such national geopolitical concern that you couldn't report it. But I quickly understood when there were the cases that occurred in Tajikistan. Rospotrebnadzor Institute in Russia quickly put a ban on dried fruit, nuts, and children under the age of 5 from Tajikistan. And so it does affect trade and commerce. And to see that happen it was very highly unlikely that it would be carried by the dried nuts or the fruit, but they also banning children under 5 years of age when in fact most of the cases were in the cohort of young adults. And when looking back and understanding that, it really was when the Soviet Union dissolved. There were cohorts who were not vaccinated anymore because everything came from Russia to the countries. And so if they weren't getting vaccine at the time of the wars or the conflicts that were going on, there was a whole cohort that weren't vaccinated. And that's exactly where the polio virus found its roots and took hold.
So how did this play out? You have countries that are, for very good reasons, hesitant to report.
We've seen it. We've seen it in other places as well, and we see it maybe at some levels, especially now when a country is getting close to zero, and maybe not wanting to say, "Oh, we got a case. We have to put our hands up and say we have one." But I think now. The world has changed such that, and the surveillance techniques using GPS and using having people down to the community level as we do now, the volunteers, that it's harder to hide things. And when we do find that, we can look at that, we can triangulate the data to say, okay, the surveillance is not adding up in terms of what they're reporting with their acute flaccid paralysis, with their stool adequacy rates. So something's going on. And when you dig down, you can find those problems now. So it's harder and harder to physically hide the virus, but the virus is still hiding from us, that's for sure.
In terms of change over time, does that reflect the experience of the polio program? Like just over time, you've learned where to look?
I do definitely believe that, and I think we've really understood where the hot spots are over time. The continuous quality improvement that's been put in the program, and I'm not talking, well, sometimes it's day to day in countries or month to month, but some of it has been, we've seen over a decade, the ability to look at using, moving from trivalent vaccine to monovalent and then bivalent vaccines as well. But with the surveillance, really being able to hone in with the genetic understanding the genetic typing, understanding where the virus is coming from, and being able to match those. And with the environmental surveillance, which we've expanded, has really brought us the ability to see where the virus is. Even if we're not detecting cases of acute flaccid paralysis, we can see it circulating in the environment, such as Pakistan right now.
Spoke a few minutes.
Go ahead.
Okay. Spoke a few minutes ago about Western Europe really having different needs or different interest in working with WHO. So I wonder if you could describe what it was like to work with Western European countries.
You had to prove yourself. You couldn't just come in and say, we're the WHO and you should listen to us, because many of them from many of the countries are being the advisors to WHO. So you had to prove your worth. And that's something also I learned quickly is how do we do this? How do we provide value to a Britain, to a France, to a Germany, and still get them engaged to make sure that they're reporting? Because many of them had sort of stopped the surveillance systems a bit. We're reporting enteroviruses sometimes, but we really needed everybody to have a strong surveillance system and to make sure. These countries did have issues with vaccination, primarily more so around measles, France with hepatitis B, but there was still a need to make sure that they could create a demand for immunization, that their populations were getting vaccinated. And it was really making sure to engage them, to bring them into some of the review of their data, as well as the entire region. So we would bring people from the countries together to look at the data together and have those reviews and make sure that they could provide comments and recommendations. And that helps to build that trust, to make sure you value what they're doing and that you can also see how. Also, I looked at how we could do some peer-to-peer. So how could the UK help Ukraine on a laboratory issue, or how could Germany support Moldova in looking at some surveillance issues. So it was really trying to find the ways to bring the countries together, which is something that they are truly not, even though they're in the European Union, they are not together on their health. They have kept health as their sovereign national right. And so I truly believe that making sure that they were brought in as both advisors, that you could then discuss the issues more that way. And when the pandemic flu hit in the region, that's something where they quickly turned to WHO and said, okay, what do we do with vaccination? Do we use adjuvant or not? And some of these issues. So it really did have to create building that relationship.
I have a couple of different follow-up questions, but I'll return to those later. I think it probably makes sense to continue moving forward in time. George Oblipanco is part of this project. Yeah, he was interviewed in March.
Yeah.
And I was wondering if you had any stories about George Oblipanco.
So being the naive person I was when I went into the region, I didn't know of him, but I quickly learned about him, and he reached out and said, "Rebecca, anything I can do to help you, please let me know."
What are you thinking?
He became a real trusted advisor to understanding the countries, especially the former Soviet Union. And he was a giant in polio. I mean, what he had done in the region of creating Mechacar between the Eastern Mediterranean region and the European region to make sure as people move between countries that we could make sure that we could shore up any immunity gaps there, and the surveillance could detect any viruses. He was a real counsel to me in terms of when I came to the region and understanding the countries and just the history of what they had been through to get the region polio-free in 2002, and the last cases occurring in Turkey, and how they had gone through all the governments and political issues to reach that. But he became a true friend, with advisor, and I'll always hold a special place in my heart.
Could you share some of the history that you learned from George Oblipanco?
I learned that all the countries are not the same. I learned that there will be diseases that may not be reported, the things that I've mentioned already, and also how to get countries to talk about the spread of polio or polio cases, even if they weren't going to report it through their national systems, that they would still, you'd have this working relationship with them, such that he taught me about how things happened on the side, but you still kept moving forward. He also taught me how it required bringing people together to talk and to make sure that you were discussing the same issues, that everybody held the same importance for polio and eradicating it or eliminating it from the region, and the value of working both at technical, but also what I learned in the European region, especially from George Oblipanco, was the importance of the political reach, that you needed to talk not only with ministries of health, but you had to reach maybe prime ministers, presidents. You had to reach higher in order to get that commitment from countries to be able to work and to stop polio.
At the political level, who handled those relationships?
Well, interestingly enough, the regional director did quite a bit of it. But where I said interesting enough was because also I got quite a bit engaged in this, and I worked with princesses and queens from Denmark and from Belgium. And Monaco, bringing them in terms of champions for the immunization and polio work in the region. But you brought in the first ladies as well. We had the First Lady of Georgia involved in this. So the importance of understanding that and bringing them in was also something that I had to take on, in addition to doing some of the technical work, was also making sure that first we went to the political level to get that buy-in, the commitment, and then we could work technically.
So interesting. Could you tell a few stories about working with some of the women in particular?
The princess, or now the Queen of Belgium, she was amazing. She was very much involved in supporting immunization in Belgium, and I worked with the University of Antwerp with Pierre Van Damme. And he had her, every February he had a immunization Valentine's month for immunization. And he had a conference, and I attended, and she was there. And then she invited me to her palace that March, so we could host a high-level luncheon to talk about immunization in the European region. And I remember sitting there in this living room, one of many, I'm sure, and she was talking about leaving that Sunday to go to the wedding of Kate and William in the UK, and what they were going to be wearing. And I'm like, this is so not my world. I will not be attending this wedding. all the hats and all the kids. But it was really, it was the work and talking about polio, talking about immunization was just like I was talking with a coworker, and in terms of her ability to, the importance of it and her ability to talk about it technically. So it was really great to work with him. And then she would say, well, then now you need to get, the Queen of Monaco, and you need to bring in the princess from Denmark. And so we would do that. And they were very interested, asked a lot of questions, but gave their names and gave their time for the children and to work on these important initiatives in the region.
Do you know if they had been engaged at that level of intensity? In the past, whether they had been as involved? Or?
Not as much, no. I think once in a while they would give their name for a cause or be the ambassador for a certain initiative, but never the level of engagement. I think we definitely took it to a higher level engagement and created many of those moments along I always like to think of it as the movement for polio eradication and creating many moments getting there. And so we would try to find ways to create those. And after I left, they have continued those and really found ways to engage them even more, which is great to see. They do take a lot of work, but they're worth it.
In terms of publicity, in terms of appeal to the public?
And very much so in the European region, yeah, very, very high appeal. Even Western royalty bringing over to Eastern Europe was also seen very highly, yeah. It was very interesting. And then, of course, all sorts of athletes. For the football stars were always a good draw with bringing groups together.
Interesting. Let's see. Anything else that you would want to include about the European region?
I think it was the first time in my career. It was really complex because it wasn't just about doing the technical work as we've talked about, but there was that political dimension as well, and that you had to bring into it. And the two worlds collided quite a bit. In order to do the technical, you had to do the political. And I think this was the first time I fully grasped and had to really rise to the occasion to do this. I saw countries very committed, though, and having the ability to stop viruses, to stop outbreaks, but really needing, in the eastern part of the region, really needing that technical knowledge that had not been there. I will remember one outbreak for measles in Ukraine, where the textbooks they were using for immunology was from 1949 in Russian. And so the importance, we spent a lot of time of translating more recent science into Russian, so that people could have, scientists and people in public health could have access to that. And now I've heard that's even BMJ has continued quite a bit of that work, converting journals as well, to really opening up the area of science and public health to people in Eastern Europe.
Hey, I'm returning to George Oblipanco. I was able to speak with him by phone, but someone else did the interview. And I remember him speaking about Kosovo a little bit and working in these countries that were formerly the USSR, and how he did that. So you began working in the region in 2007? In 2008, thank you. So I wonder, in addition to what you've already shared, if there are memories that you have of times when you went, I'm seeing the connection to the former Soviet Union.
I think when you said that, it reminded me of Bosnia Herzegovina, which is actually it's a small country, but has basically three countries in one. And one could not report to WHO, one of the Republic of Srpska could not report, and such that we had to get their data through another route. We couldn't get it directly to WHO because it was not a recognized member state of WHO, and it wanted to be on its own. And we had pockets, too, when North Ossetia and South Ossetia broke off from Georgia. The North Ossetia was with Russia. And so again, if they didn't report through the Russian Federation, we wouldn't get their cases. So we had these silent spots that had come up, to your point about different conflicts that had occurred over time that were not connected to their respective countries anymore. They were new sovereign areas. They wanted to be on their own, and parts of between Azerbaijan and Armenia to understand the political situation there about who reported to whom. When we set up the regional laboratories, so Georgia used to send their specimens to Russia. That first time when Georgia and Russia had the war, and then they split, we had Georgia now sending their specimens to Luxembourg. So again, you have to think about, because they couldn't send them to Russia anymore, they didn't want to do that, but you have to figure out, how are we going to do this then? And how do you make sure that you can make sure that all kind of suspected cases are tested and we look at specimens? So you had to match up areas where there wasn't conflict or where they could get along or get information, as I said, sort of through other sources, not directly. And I think that was some of the aftermath of seeing what we had based on what had occurred earlier in the Caucasus and the Balkans. Yeah,
I'm interested in the ways of the word that's coming to mind is circumventing, but that's not really what I mean quite. But finding alternative ways of getting things done.
Exactly.
Could you give some examples in addition to what you've shared?
Yeah. I think one of the big one was always, if you knew about, so I knew that there was a case in Republika Srpska of acute flaccid paralysis. We didn't know if it was polio or not, but we needed to figure it out. So we had to find a way to get them to send the specimen to some place where they could get tested, and it would be done in a lab that was accredited. And we had to work through almost 2 layers of government and through the public health systems, so that they didn't know that we knew about it or that they were asking them to test it. So it was done in such a way that through contacts and through people who knew each other before different lines had been drawn in a country who worked together could share information. And so that sort of some ways we heard about reporting as well, or carrying out specimens from different areas to be tested in pant pockets or in coat pockets, have had that happen too. Bringing test kits in suitcases to countries and then somebody else transporting those into an area where they needed to be tested. So a lot of that sort of, done person by person or people that you knew of how to move things around, in addition to what I've said about hearing things off record after meetings, building that trust, having the tea, having the meals that you needed to make sure that you could get that information shared.
Thank you. Anything else about your work in the European region?
It was an incredible time, and I think I went in thinking, they are already polio free. We're just gonna, sail. We're just gonna, sustain it. We just have to monitor, and then to see that importations, and like we talked about, importations can occur as long as polio virus is in the world. There can be importations anywhere, and we saw that truly happen, and to see such a large outbreak occur was really dramatic. There were deaths, and there were a lot of adults who were affected by this. So I think the importance of really making sure that we keep up the surveillance and the immunizations everywhere until we truly eradicate the disease are really critical, and that was a true lesson for me to see that firsthand.
Thank you. So you left the European region in 2011? Is that correct?
December 2011. I was back here in January 2012, yeah.
Okay, so also in December 2011, Dr. Tom Frieden moved polio into the Emergency Operations Center. Could you talk about your transition into the EOC?
Yes, so it was August of 2011 when I was interviewing for the Global Immunization Division directorship, and I got offered in late September, and then October, I said yes, early October, and we were figuring out dates to come, and we finally agreed, okay, it'll be January 2012. And then in the whole interim, after I'd accepted the position, just what you said, it was like November 2011, Dr. Frieden moved polio into the EOC. It's an emergency. We're going to do this. And I was like, what am I walking into? I mean, half of my division that I'm going to be supposed to directing will be in the EOC. How does this play around? I hadn't been at CDC in Atlanta for over 10 years. I'd been in the field now for 10 years. So knowing how things were going to work, how this would be, I was walking in a little bit with just trying to understand and just saying, let's just breathe and we'll figure this all out. And I got here, and it was a mass stand-up right away, of course, and there was a lot of movement. And it really was one of the, at that time there were 2 branches in the division, and one whole branch was moving into the EOC. And so trying to figure out like where their work was connected, because we always tried to make sure polio was connected with the rest of the immunization work. How did we continue to do that? How are we allowed to still build on the measles, rubella elimination with the polio work? Staff were not sure, how long are we going to be here? What are we going to be doing? So there were a lot of questions and a lot of unknowns at the time. But the importance and seeing, I was really excited because I thought, yes, this is really going to be important, and the director really believes in this, that we can do this, that we can eradicate this disease. And with this extra push, we saw right after Dr. Frieden declaring it a public health emergency, WHO doing it. And so it was really exciting to see that it had momentum and that we really got that push we needed, because it had been decades. We had just been sort of almost a decade, 10 years, just been kind of going along with the same amount of cases and just maintaining, but we didn't have that real drive. And I think that's what it brought to the program at that time.
Could we go back to August
Sure.
of 2011? Yeah. Could you tell the story of your transition into being director of GID, Global Immunization Division?
Well, it wasn't. I mean, I had, it had been posted, and people were asking that I come back and do this. I had reached my time overseas, so I needed to come back. And of course, you're wondering, can I do this? Can I really make sure, this is some big, lofty goals that we've got to make sure that we can achieve. But went through the process and was offered the position. And then they said, well, can you come tomorrow? And I'm like, no, I got to finish these things. That we got to finish these things in the European region. So that's why I waited until December. But was following closely in the region. I would meet my colleagues at WHO meetings, at the Independent Monitoring Board meetings that were being held. So I knew very closely what they were working on already and what CDC's important role was day to day in polio eradication.
What were you hearing from the Independent Monitoring Board?
At that time, it was like, this is totally off rail. It's not going anywhere, and there's no way you're going to achieve eradication with the strategy that you've got in place right now. That was very clear.
And that's the strategy at that point. This was the strategic plan for 2010 to 2012?
Yes.
Okay.
Yeah. And then that was quickly rewritten when we got, actually in early 2012, we started to work on the end game strategy and get that into place. Yeah. Because every time we would do these, we would put a date for eradication in and miss it. And so it was saying, okay, now let's go a little bit further out this time with the endgame strategy and take it out to make sure that we cover and truly can achieve the goal. But here we are.
I've often wondered about the meaning of the target dates and what it means to people personally and professionally when these target dates are missed, when they go by. How do you remember having been impacted?
When the earlier dates that had been set and that were missed, you really felt those. And it was like, I can't believe we'd missed this again, and what are we going to do differently? And really ramping up again to do that. But this time with the 2012 and with moving into the EOC really did set a whole new tone for we can't miss any more dates. I think we got to a place over years where you just started to realize we're going to do everything we can, but we might not make the date, but we need to have that goal. And part of it was for donors as well to know this isn't going to be forever, because that's one thing they said is like, when are you going to eradicate? We've been doing this for 30 years. And how do we continue to make sure that we can have the resources needed for this? But it is sort of that personal, we saw in 1988 with over 350,000 cases go down to, late in 2011, we were then down to the 4 with India, Pakistan, Nigeria, and Afghanistan. And then with India being taken off the list in early 2012, we're down to the 3. And so both of that, going into the Emergency Operations Center, seeing India come off the list, was really exciting to say, okay, we can really now move this forward, and we've got to put everything we can. We have to work as it is an emergency. We have to put the best people where they need to be. We can't take any chances. We really have to do that. And people sacrificed a lot to make sure that we could. And we worked, we would have biweekly meetings with Dr. Frieden, and he was just in the weeds with us too, talking about surveillance in Nigeria and Borno, and how were we going to find those 5 workers that could go there because we could not, due to security, go there. And then we would follow up and move forward. So it was really, everybody was living and breathing it to make sure that we could meet these goals. And we did see continued decreases in cases that we have. We did see at one point Nigeria go to 0, but that was reported, and actually there was virus circulating still. Again, there are no cases reported now for almost 2 years, but we're not pulling the trigger so fast this time on that one.
So and could you talk about early 2012 and maybe just walk us through 2012?
Yeah. So I think everybody and GIG had to figure out what we were doing in the EOC. We were, Global Immunization Division and Polio has been very much a partnership of part of the Global Polio Eradication Initiative with WHO, UNICEF, Rotary, and Bill and Melinda Gates Foundation was coming in more and more. And we worked sort of, the way we needed to work and did what we needed to do. And we were put into this very command control environment. And it was very different from how colleagues had worked. So we had to learn how to work in this command control, and there was a whole new organogram built up in terms of logistics and international relations. And each of the countries had a team as well, a task team to work on. So we tried about 3 different organograms of what would work for us, and finally landed on that we really needed to focus on the countries. So Nigeria, Afghanistan, and Pakistan. And then we had sort of the rest of the regions. So we would have a WIPRO, and we had a Euro, and made sure that we could follow it. But it did take us time. Over time, we developed to say, okay, we're not getting where we need to get with this, and we need to think about organogram. We had at that time 2 different incident managers. The first one came aboard, Rob Lincolns, and then stepped down, and then we had Greg Armstrong come in. And he was for most of the part before John Vertifay took over. So while I was in GID as director, I had 3 different incident managers the entire time, each one bringing different strengths and different skills to it, but helping us to continually progress and move forward our efforts and part of our contributions to the Polio Eradication Initiative. But people spent a lot of time. We'd send people out for 6 months, 3 months. We changed the Stop Transmission of Polio program to 5 to 6 month extensions as opposed to 3-month periods when people would go out. So we did it twice a year. We really figured out what worked, what didn't work, and tried to make sure that we could implement that. I think some people got it was a lot of stress, and people got burnt out a bit, and we'd have to rotate them in and out. So I had to figure out, when I was hearing, staff say it's just too much right now, I really need to step back, and how to bring them back into the division, and use staff from the other programs, be it from the immunization strengthening team or from the measles rubella, how to bring them in and have some rotations through that as well. And then to figure out, how do we link our work? Because if we're making all this effort, how can we bring on it some of the measles rubella elimination? If we're strengthening a surveillance system in a country, why can't we also then think about they're picking up data on measles rubella when they're at a facility or doing a training? And so without disturbing or making sure we kept our eye on the goal, how do we make sure we can bring our other programs as well to make sure that we can bring more efforts to saving children? And so these were things that we had to think about. I had to work with colleagues to see how we could best address, and then also the continual staff. We only had many term positions or temporary. We didn't have permanent. And so bringing people on board and trying to get the best of best people at this time, people were permanent, but we couldn't hire them all because we didn't have, the permanent positions to do so. And so we had to do negotiations on that. We did have Commission Corps officers who signed away being in the Commission Corps so that they could do polio eradication. Not a lot, but a few. And we also had people who were near retirement come on and say, I'll go into a temporary position and then I'm leaving in a year or two. So there were different ways we made it work to get the best people that we could at the time.
Could you explain the working relationship between the role of incident manager and director of the Global Immunization Division?
Yeah, that was we had to figure that out too, each one of us, and the different people that I worked with. It was really because the incident manager does report to the CDC director. And so we report directly to Dr. Frieden. But we made sure that I attended their EOC meetings. I made sure that the biweeklies that we would have with Dr. Frieden, that I was there. I also, within the Global Polio Eradication Initiative structure, stayed on as the strategy committee representative for CDC. And the incident manager was working at the outbreak management team, the emergency outbreak management group, as the head of that. So we worked very closely in that structure as well, but really had to leave room for the incident manager to truly lead it. And just be more of the advisor, support, and consultant, and make sure that he had what he needed at the time to do his job. And that's what I did, trying to figure out the roles at the time, yeah.
What were some of the resources that were needed?
So additional funds were needed, so financial, and I spent time up in Washington informing Congress and congressional staff about our work. I would bring people from the field to tell their personal, stories of what was happening at country level, so that people could see polio is well supported in Washington. People see it and recognize it, and it was not seen as a divisive issue. So everybody appreciated the stories and understood where vaccines were going. So I spent a lot of time doing that up in the Hill to get the Washington. And then also within the space, within the HHS and the National Security Council. So those were two other layers as well that I spent time informing and making sure that we were telling them what we were doing, but also what we were having success, where we were having challenges, how U.S. ambassadors could help in countries, for example. Dr. Frieden and I and the incident manager used to have calls once a month with the ambassadors in Pakistan and Afghanistan to really go through the progress and what were some of the issues happening and what we could do and how he or she could support us. So we would do those. Then in the realm of the Polio Eradication Initiative, the interagency space, if there was something that the incident manager needed, for example, CDC believed in Nigeria that we should do a larger area for a campaign, and maybe WHO said we should do a smaller area, or we should do longer times between campaigns. This is another thing where I would work with my WHO colleagues to talk about this, and Dr. Frieden would reach out to Margaret Chan directly, and then we would contact the country. So there were many of those issues where we would support the incident manager with some of those efforts, both on resources for financial, but also for positions within the division to support within the incident management system, and then also the political and the interagency or the inter-partnership as well.
Where would you say that you spent the most time negotiating?
Probably in the interagency space, and then also just trying to understand the politics of each of the countries to know who were the biggest influencers and how you could do that. Of course, Mr. Bill Gates was able to pick up the phone and talk directly to any president or prime minister, and that was actually incredibly helpful. But how could we use what U.S. resources we had to support it as well, and trying to understand that? So there I've spent quite a bit of time as well, yeah.
Working with, when you say interagency, You mean within the partnership?
Yes.
Okay.
Yeah.
Could you speak about some of the other partners? Rotary International. You mentioned Gates. UNICEF and Rotary, maybe.
UNICEF and Rotary? Rotary is an incredible partner, and it's something I say whenever I give presentations about polio, to say the fact that, every large initiative needs a Rotary Foundation. What they bring to the table is just amazing and incredible, that they have people down to the community level, grassroots level, raising funds and keeping the momentum alive. It's powerful to speak with Rotary clubs. I've been doing many of them in Missouri and in Chicago and here in Atlanta. But the opportunity to really speak with them is incredible, because they really are committed to this, and the funds that they're able to raise. But the one thing I learned, and I learned this actually during the Tajikistan outbreak, is, people in Rotary clubs or Rotarians are influential people in countries. And so the head of police in Tajikistan was largely helpful in us being able to do some, SMSs and doing mobile texting. So really understanding in a country who are the Rotarians and how they can really influence and help with the political commitment. They've also been really important and key role also in bringing together when communities are tired of just receiving polio drops. They're like, we haven't seen polio, we don't want any more drops, but we really need, water and sanitation. We really need nutritional support. They've played an integral and vital role in working with the communities and the influencers and stakeholders to be able to see how to integrate some of those services with the polio vaccination. In India, they played a key role in that. So that's been a really important role, and their voice is so important in this initiative. UNICEF is along the lines with UNICEF, with Rotary. The communication and the social mobilization at the community level. One thing I noticed is, we were really good about putting big banners up in terms of campaigns going to happen and, T-shirts and hats. But that interpersonal communication about convincing a mother or a guardian to get their children vaccinated, we didn't really use those data together with the epidemiology that we had. So putting the communication data with the epidemiology, the surveillance data, to really understand how after each round of immunization campaigns, we were using the best data to inform the next round. And this is something that, working closely with UNICEF, and we gave them funding for this, they started to do more. They did Harvard polls. They worked with Harvard University to do polls to understand what people felt about polio, what they thought about the disease. Did it really, cause death? Did it cause, disabled people? Or was it just something that didn't? And to understand people's thoughts of the disease, but also what they thought about the polio eradication program. And going into that, they really were able to reduce the number of refusals or missing children during campaigns. They would just have missing kids, but it really was missing because parents didn't want them vaccinated. And so really cracking that, getting down, UNICEF has played a huge role. The other very big piece of work that UNICEF does is making sure that all the vaccine is there. They do all the procurement for the vaccine. And to do that, I've worked their headquarters is actually in Copenhagen. So when I was based in Denmark as well, I worked closely with them, but really understood at that time. I mean, it's a huge logistical operation, what they do to be able to get vaccine on planes to the right place for a campaign, working with the vaccine manufacturers to make sure that the forecasting that enough vaccines being produced when there are shortages, how we're going to address it. I mean, that is a huge piece of work that UNICEF does that is incredible, and it's not an easy role at all, but really phenomenal people who are dedicated and work hard and who've been there for over 10 years doing it.
So we're still in 2012, and I'm going to do a time check also. We have about 25 minutes. So clearly a lot happened between 2012 and 2016. Three of the things that I'm thinking about are the InStop program, also the ban on vaccine in Pakistan and how that shifted the picture, and then the switch, which I'm actually not sure. Were you involved in planning that? Okay. 2016, I'm not sure. When did you exit the GID director?
It was September of 2015. I went up as acting director for the center, but at the same time, because I'm on the strategy committee, worked very closely and also with the incident manager here in Atlanta. So, yeah, been integral part of that.
Wonderful, wonderful. I thought so. Good, good, good. So where are we in time at this point in 2012? Are we still in the first quarter of 2012? You're having biweekly meetings. You've set up infrastructure. Okay. What happens next?
So I think some of the next things that start to happen is we start to see the killings of health workers, of vaccinators in Pakistan, a few in Nigeria, and then we see the Al-Shabaab in Somalia as well. But we start to see that, as you said earlier, we were able to hone in where the disease was, and these areas matched exactly where we also had insecurity. So we had the Taliban in Pakistan, we had parts of Taliban in Afghanistan, different groups, and then Boko Haram in Nigeria, Al-Shabaab in Somalia, where we were seeing some cases that had popped up for importations. But the overlap of these areas really put a stop to what we were able to do. And when I had come in already, there had been the ban on vaccination late in 2011 for the North and South Waziristan, where there had been the fatwa against vaccination, and trying to understand how to deal with that. How are we going to vaccinate? And we weren't. We were vaccinating kids as they were leaving, but we were seeing huge outbreaks occurring in Pakistan in this area. We had Elias Dury, who was the WHO polio team lead, but he was on detail from CDC, so he was a CDC employee. But what he was able to do in Pakistan is pretty remarkable. And again, I said, to having to work with the politics, work with military to see how to get in and how to get kids vaccinated. And we knew how they were moving from the north down into coming into Islamabad or into Karachi and Quetta. So we understood how the populations were moving, but we needed to vaccinate them before they started to move, because we knew that we wanted to stop outbreaks from occurring in other areas, and we wanted to make sure that all kids were protected. So he worked I probably don't even know half of the things that he did. But I know that he worked with many different groups, and especially with leadership with Imran Khan up in the north in Peshawar, to be able to start days again of not just polio, but how do you bring other health services together for the community and to get people out to get vaccinated. The use of the police and the military to cordon off areas so that you could vaccinate safely. And we saw killings of police officers as well. It was a stop transmission of polio officer we had he was based in Karachi, and I got a call from Elias one day saying that he had been shot. And he had been in a gadap actually in Karachi, and he was getting care, and they were going to be able to medevac him and get him services. But after that, then we started to see more and more of the killings, and it was really tough. I remember Elias would call me 3, 4 in the morning, based on what time it was in Islamabad, and phone would go silent. And he'd say, "We lost another one." And I being very far away, but just couldn't even, how I felt, couldn't imagine how he was feeling in country about his team. And vaccinators would still go out and vaccinate the next day. But really getting the engagement of the government to get the police and military involved was such a critical change to making sure that we could vaccinate. But also with seeing these insecure areas, we recognized that we couldn't go in there as U.S. citizens. We couldn't send our staff in. WHO as well had, security issues and couldn't send people. So we had to figure out how are we going to do this. And this was the brainstorming of the idea for the National Stop Transmission of Polio team that came out of Nigeria to work in Borno at the time and Kano states, where we needed to make sure people who knew the area, who could get in, could do programs, but who were strong technically. And so we built that off of our field epidemiology training program colleagues that had graduated. And to date, we have over 300 in Nigeria still working in Borno and Kano State, but they were able to be in their communities. We could work remotely, we could monitor, and it was a way to find a way to work to continue the efforts and make sure that we could do this. We've also used similar programs in Pakistan and in Somalia as well, people that had attended the FATP program in Kenya. So the NSTOP idea was born in Nigeria. We've since expanded it to Frontline for malaria as well. So it's been a nice continuation to see the impact and how we've been able to do this with malaria. And it really wasn't to be more workers into the system, but it was really to be sort of provide that supervision, the accountability, the oversight, and to do surveillance. So to be another layer and to really ensure quality. And to report if things weren't working. So that's been hugely successful and was taken over into Pakistan as well. In Afghanistan, we tried something different. We tried polio workers in the community and had some success in that. But again, in areas, anti-government areas, it's again, we leave that to the UN to figure out how to work with those communities and to really understand about when we can go in and hold immunization days. How do we think about doing the supervision and doing the monitoring? Because you're just having to look at something, a piece of paper, and say, okay, this is what they're telling me. Is this true? And then maybe 8 months later, you'd see a case of wild polio virus. You're like, okay, so maybe these data aren't true. How are we really going to be able to triangulate or validate these data? And how do we build systems and people that could do that? For the monitoring in Pakistan, some of the areas we even had to look at people in markets. We would just, look through for children in markets and see if their fingers had been marked or not. And so really just seeing what you can do with what you've got and having to be innovative and flexible at the time and really brainstorming and really leaving it to people on the ground who know the situation best. We could have all these great ideas back here in Atlanta, and we did, and we'd share them. But I think the real the real genius ideas really came from the field, understanding the issues. I think we could provide some ideas and overall settings, but really they needed to do it themselves in figuring out what would work or what wouldn't work. So that's insecurity was a big one. And then we talked about the NSTOP. So those were sort of the next big things to come along. And then, everybody got excited when we saw Nigeria become polio-free. And we thought in 2014, this is going to be it. Made a big declaration. Everybody was thrilled. And then you get the notice in 2014 that, it's like, actually, there's a case. And it's, been circulating for at least more than 3 to 4 years. And then what do you do? And people, partners lose trust in what you're doing. Your credibility gets a little bit shaky. People say, how can you not have known this? And we have that period we use of 36 months since the last case to say that's when something would be polio-free. So people are saying, well, we were almost there. You were already into 24 months. And how would you could have missed it, and you could have declared it polio-free. So I think that these things have really brought new awareness to us about how we use our words, how we describe things, and to be very clear about an area when we're saying if it's polio-free or not. And I think with Nigeria, we've been extra cautious now. As I said, they're going on again 2 years, but they're not going to. We're going to be making sure that they've reached every child before we make any proclamations about their being polio-free again.
What would you say are some of the lessons learned from Nigeria, whether that be technical lessons or other parts of implementation?
Nigeria, there's been a lot of learning. I think the for technical, I think, as I talked about, the end stop was a big lesson to learn there about how do you work in insecure areas. And then it was thinking about the accountability. We knew vaccinators were going out, but there were still a lot of missed kids. And so working with Gates Foundation, which was putting GPS trackers with the vaccinators and being able to map where they went, you could easily see like they had done all this area but had totally missed this area up here. And quickly seeing that, we could start to map. Our EOC here was able to provide maps of satellite images to understand where populations may be living or not, to know was there a village there, were there homes there, or had people moved on. So you could tell by the growth of the vegetation if there had been habited there recently or not. So all of this has been really helpful to overlay, to understand where are the populations, are we reaching all the kids? And the environmental surveillance is the other piece that has the expansion of that, and new techniques to collect the water samples better have allowed us to be able to expand environmental sites to understand if virus is circulating or not in the environment. So those have been some really big things for Nigeria. Nigeria came along and we saw that continual drop because they had just been continually with the same number of cases. The political commitment from the president. He created a president's task force, and he brought all the state governors in, and every month. And we here at CDC had created a dashboard. And so showing a state, red, yellow, green, their level of preparation, really created sort of a competition. And they'd go back and talk to their, local government authorities, the LGAs, and having that level of commitment from high level really made a difference as well. And we saw that. And we worked very closely then to bring that into Pakistan, and how we would work with the provinces and the prime minister. And there as well, Senator Aisha was put in as the polio coordinator, and the Emergency Operations Center was created after seeing how well the creation of that in Nigeria. That was another strong creation in Nigeria, was the Emergency Operations Center, both in Abuja and then the satellites. Because what that did is it brought all the partners together, working with the government and the government being in control. But at least we were all talking and deciding things together. So it wasn't CDC saying, in here we need to do 3 campaigns, and WHO saying, here we need to do 2, and we should use bivalent and we should use monovalent. So it really brought that together where we could hash it out and have those discussions. And I got a lot of phone calls about those meetings too, because some of them got pretty heated. But I think in the end, they all turned out to the level of that needed to happen, and people came around to seeing what was the best technical situation. And we had a few phone calls from Dr. Frieden to Margaret Chan at the time to help as well. But I think that all of those pieces, the external support, but really seeing the EOC have that leadership was so strong. The Gates Foundation then funded the ones in Pakistan as well. And then Senator Aisha, working with the incident manager, we created a similar model. Afghanistan was slower to the page to come for an emergency operations center and to see how it could be operationalized because of polio. They didn't want to make polio such a government thing, such that the anti-government elements would not want to participate. So they had to be very careful about that, and that brought a new twist or nuance to some of those points that you had to consider. But it was really some of the innovation of the political commitment, the accountability, the Emergency Operations Center, the end stop really came out of Nigeria.
You mentioned Senator Aisha from Pakistan. Would you speak about her work a bit and tell some stories about her?
I remember when I first saw her was actually in Delhi. We were celebrating the polio-free status of India, and for the CRO region, they had been declared polio-free after 36 months. And she came up to speak, and I was like, "Oh my!" She seemed very young, but she's a force. And ever since then, I've really appreciated her and really respected the work that she's done and what she's been able to bring. She she has rolled up her sleeves, so to speak, has really gotten involved, and she, sits at the Emergency Operations Center in Islamabad. I've seen her there many times, but she has been a force, and working closely with the Minister of Health, Minister Saira, they have been able to really have an influence in working with the provinces and with the provincial leadership to get that political commitment. She has also brought how do I say this? Sort of the an integrated approach to polio eradication, bringing the political commitment, bringing the technical people together, and she has really garnered the credibility from the international community too, that Pakistan can do this, and we still continue to see the drop in cases there. And she has not given up one day. She has remained in the fight.
So I'm wondering if we should move on to the switch. Is there anything else you would like to say about lessons learned 2012 to 2014?
I think what the last thing I'd want to just say on that is really the political commitment really does need to be working. And it's not something you just have all the time. You have to continue, just as with technical, and you have to continually develop the technical skills, and you have to figure out what works. And we think about new science that can be brought in. You have to continually work with the political commitment too, because if you don't, this just sort of coasts. The other work just kind of coasts as well in terms of people engagement at the lower levels, and you really need to keep that momentum going. So the political commitment and keeping people accountable. One of the things I think too, both in Pakistan and in Nigeria, is that we went through quite a few of the workers. Like, if you aren't able to meet these goals, you're not going to have a job. Or if you were found falsifying information, people were held responsible. So that accountability, when people saw that, those were both very important pieces to go along with the strong technical work that we had to continue to do in programmatic. So those four elements are really important in any sort of initiative of this type, and have taken us to date where we are. For the switch, it was actually the Eastern Mediterranean region that brought the idea to SAGE, and they wrote a letter saying, "Why are we using this? We should switch." And it took almost a good 24 to almost 36 months to get any sort of traction. And then once it did, okay, we're going to buy into this. Again, UNICEF thinking about, here you have, it wasn't 194 countries at the time, but a good portion of countries using trivalent OPV vaccine and IPV. And you're going to one day tell them all to pull all the trivalent vaccine back, and you're going to destroy it, and next day you're going to have bivalent and IPV. And we developed criteria to say, okay, in order to do the switch, you have to meet A, B, C, D, and one of them was to have IPV available. And as we started down this route, we quickly recognized that the two manufacturers that were making it were not going to have the supply. As then it was a big discussion about, do we go forward? Do we not? And there were a lot of heated discussions about that and considerations, but recognizing it was supposed to be, the dose of IPV was supposed to be risk mitigating in terms of protection, but we should still do the switch. And so the switch moved forward. Again, we sent out people. I even added people from our PEPFAR, the President's Emergency Plan for AIDS Relief. We have implementing partners in countries, and I had them also engaged, asking them to go out to the clinics and to check refrigerators, check freezers, make sure that there's no vaccine out there, and used every resource that we could think of to do this. But building up, there was the team that was working on it, the cross partnership team that was working on the switch. We'd get updates on the preparation about, okay, you got to make sure every country has access to bivalent OPV. You've got to pull the TOPV, making sure when the orders were, and making sure the orders didn't go out too far in advance, such that a country would have a lot of supply left that they would potentially use. So all of that, from UNICEF's side, was incredible work that had to be done. On the ground, working at doing the training with healthcare workers. And then the day and the week of the switch when we went and actually did this, sent out people to all the many countries. We had teams that went out with health workers to go and do the switch. So it was rated a great success and the largest switch in history for a vaccine. But afterwards, we have seen some outbreaks of circulating vaccine-derived poliovirus type 2, which means that some countries still had trivalent and were using it. Well, lo and behold, yes, Nigeria, they found freezer, a supply room at one of the states did have it. And so recognizing again that we had to do a much thorough search of this. And just as we do with surveillance looking for virus, we had to do the same with the vaccine. DR Congo is another one where we've seen outbreaks. And so I think this is it's been a good learning lesson, but I think on the backside, we've created since then risk countries that we thought were at high risk to potentially have the vaccine trivalent, and having to send out teams to actually go and look at all the different levels to make sure a vaccine was not there and to pull it if they did. So that's been an interesting procedure. The other interesting piece was the IPV. Countries were very upset because they had been told these were the criteria. And then we're starting to change the criteria just to say, no, we want to get the vaccine out. So we want to do the switch. So you don't really need it now. Well, they had been told that and they really wanted it. And we saw some countries start to do special arrangements with vaccine manufacturer directly at different prices. We saw the PAHO region, which had planned to have 2 doses of IPV, move to 1 dose, but again, they were upset about that. And so there were a lot of moving pieces, and I think the communication on it, I think we could have done better in terms of what we were trying to say and when, and the importance of what was needed. And I think we all internally understood, but I don't think we did a great job communicating to all of the member states and making sure they were on board and understood as well.
Has part of your role been to communicate progress to the public and to the architecture of the GPI?
Yes. I've mentioned doing the Rotarian talks. I've done a lot up in Washington with Congress and the National Security Council when they've wanted briefings, but also at different meetings and conferences around the world, and also for donors. We've tried as a partnership to hold meetings with donors, and then also with media. The Gates Foundation organized, over the years we've had different media approaches, but we've had such that we brought the strategy committee to meet, and each of us picks up a different topic and focuses on that and meets with the media and has discussions. So it has been a lot of discussions about the progress. We're almost there, and making sure that we can continue the efforts. I think over the years, we've recognized that, again, maybe not talking about a date right now, but talk about the progress we have made, that we have eradicated type 2. We haven't seen type 3 since November 2012. We've seen the reservoirs shrink. We've seen fewer cases. So I think these are the things now that we focus more on the progress that we're making over time. And this is what the message that I try to carry in the different audiences that I speak with.
What kinds of questions have you fielded from the media, from different bodies? And have some of them have been hard?
Yes. Of course, the big one is missed deadlines. You've missed another deadline, and what are you going to do now, or why should this time be different? That's a big one. Explaining vaccine-derived poliovirus and vaccine-associated paralytic polio are also something that are difficult to explain to people. This isn't caused by the wild virus. It's caused by, the vaccine virus, and explaining the rarity of that and how it can transform and the importance of making sure that there's high coverage. So, and it's funny, I got a call from Elias, and right before the Academy Awards, because Zero Dark 30 was up for and winning Best Picture. And he was concerned that if it won Best Picture, and that does have a scene in there of Dr. Faridi being used to help find Osama bin Laden, he was afraid that that would create a lot of problems in Pakistan again with potential killings and banning of vaccination. And I said, Elias, I can't control who wins the Oscar. I was like, I can't call anybody. But what's so funny was when they were doing the awards, they were being held out of the White House, and Michelle Obama, the First Lady Obama, Michelle Obama, was the one announcing the award for Best Picture. I'm like, no. Zero Dark 30 did not win, but I just thought the coincidence of that was pretty remarkable.
Thank you, First Lady Obama.
Thank you, yes. I'll give her full credit.
That's so good. Looking over my list, so part of this effort really is to collect lessons learned, and there may or may not be follow-up interviews. And Johns Hopkins might do some interviews as well. But I wonder, based on what we've covered today, if there's anything else sticking out to you in your memory about lessons learned that need to be recorded for the future.
I think one big one, we've talked about it in parts by different, like UNICEF, but the partnership is really critical. Having such goals are important in public health. The eradication goal of polio is a noble and important goal. And I think why we stay in this and why we continue to drive this is it really will save lives, and we can have the second human disease eradicated. But the partnerships, it cannot be done without bringing the skills and the strengths of different partners together to do this. And so the value of that, you cannot over-communicate what you're doing, but really having the importance of the political commitment, the accountability, the continuous development of science. That can't stop. You can't think you have a vaccine and you just continue on. You have to continually figure out what's going to work, what's not, and what we need. Can they develop it in time? And the importance of having all of these lanes working at the same time is so important. And the community. I think early on we thought, we just bring the vaccine, everybody will want it. Now some communities don't want it. They don't want 30 doses of polio vaccine. And we know that they've got other very important life issues that they would need to address. So that communication is so important, and then also working with communities. And I think we saw this with the Ebola outbreak as well. You can't just come tell people what to do. You have to understand the cultures. You have to understand the communities and how to work with them to get to achieve the goals. So working from the lowest level to the highest, the importance of that partnership is really critical.
From the perspective of leadership, and then having worked globally, I wonder if you would comment on polio as a global health priority?
I believe it is a high priority. In the immunization world, there's a bit of a division in terms of all the efforts that have gone into polio eradication versus strengthening the immunization program. But the polio eradication has brought the immunization program along quite a ways and has really accelerated some of the efforts. So I truly believe that as a public health priority goal, it is critical. And I do think, when you see all of the lessons learned and everything that's been built, my one important and plea is that we make sure that we use these assets and infrastructure that have been built for polio for the rest of the other public health efforts that are coming behind, the surveillance, the laboratories, the understanding how to work with the political environment, the communication, the science, all of these things that have been brought to bear on polio will continue into the next efforts for us in public health.
Anything else you'd like to add?
I'm looking forward to eradicating polio. And we're going to do everything we can to do that. It really is a gift of a lifetime, and to be part of it is a privilege and honor. And I've worked with some really big giants, and just the incredible people that have given their lives to doing this. It's just amazing. But most importantly, the children that we're trying to save. Thank you.
Thank you.